routine urine did not reveal any protein. And his diabetes part was his HbA1c was 7. His on presentation his sugars was around 180, and during the stay also his sugars did not rise. His diabetes part was controlled on medication.
HbA1c was 7. His on presentation his sugars was around 180, and during the stay also his sugars did not rise.
Somebody else.
The diabetes part was controlled.
This is repeating. Yeah. In the okay, that's fine. Any carotid finding? Nothing, right?
No, sir. There was no positive finding.
And would you be interested to know in this person's dominant hand?
Yes, sir, he was a right-handed person.
Thank you so much.
And yes, sir.
Yeah, thank you so much.
My question to Dr. Bora, sir, as you have been mentioned that this patient is having a diabetic, Prashant has been already mentioned. HbA1c is around, sir. So what is the indication of ACR in this patient? He was asking about whether the patient has been catheterized or not. Number one.
Yeah.
Number two, the patient is having urine examination has been done. What is the relation of ACR with this hemorrhagic stroke? Can you elaborate us?
The first thing I wanted to know, I'm not very sure about this. First of all, any catheterization may actually alter the urinary findings in itself if we are not very careful.
Not got the answer, sir. Not got.
Sir, any catheterization may alter the urinary findings. It depends on how it is taken.
Now, my question is, you have been asked the hemorrhagic stroke with this urine ACR report. So how you will correlate the urine ACR with the hemorrhagic stroke? That is my question.
Yeah, sir. I have no idea regarding that. I was asking because this patient is diabetic, and I was more interested in the microangiopathies. I think so. My other CTS can answer more. Yeah.
Because
Dr. Jain,
yes, sir.
Any patient with an increased UACR of more than 30 is at a very high risk of all events, whether it be MACE, CKD, or strokes. So it is a prognostic risk factor.
Exactly, sir. So again, we are coming to our student, Dr. Prashant. So after this initial evaluation, you have been done this patient is having a hemorrhagic stroke, upper motor neuron type of stroke, and this one. Next, after the controlling of the blood pressure and using the mannitol, what other measures will take care of this patient? What things will do?
So we'll look for any worsening in the neurological any worsening in the GCS. That will look for if the intracranial pressure rises. That is a important thing to monitor. The blood pressure need to be monitored. The judicious reduction in the blood pressure has to be monitored.
Yeah. Besides this, the patient is whether we have to notice the patient can be taken the food properly on these things. Otherwise, we have to put the patient on the Riles tube. As Dr. Ayanduti Bora has been already talked about whether if the patient is able to pass his own urine, then it is okay. Otherwise, don't catheterize unless or until is it required. Okay. So these are the three things, because catheterization itself causes the urinary infection and other things. As the patient is already on diabetes, there is a high chance of urinary infection.
So which is why I wanted to know about how was the urine taken, if it was taken at all, because if there is a degree of disturbance, the ACR ratio may be also because of the infection and something like that on day 2.
So it is not related to the question and the hemorrhagic stroke. What you
okay. Okay. Thank you, sir.
Third is that because if the patient is able to pass his own urine and these things, patient is conscious oriented, usually we don't do the catheterization. But if the patient is having an altered sensorium, the catheterization has been done for the prevention of this retention of urine. And next is the role of statins in this type of hemorrhagic stroke patient. To my learned all the panelists. Prashant, will you treat the patient with aggressive statin therapy or will go the moderate statin therapy?
So the patient has the risk factor like elderly, diabetes, and hypertension. So we can start with the statin therapy.
How much and which statin?
So we can start with the atorvastatin at 40.
So
moderate
this
dose 40
question is to my panelist, Dr. Virmani sir also. Sir, in your clinical practice, if this type of patient comes, should we aggressively treat the statin therapy with 40 milligram or 80 milligram atorvastatin, or we should go slow?
No. See, the patient of diabetes and hypertension should have been on a statin, number one. If he has been on a statin, we continue the statin. We don't disturb it. Because one of the side effects of in statin, maybe observational studies have shown that they increase hemorrhagic stroke. So one has to be very careful in hemorrhagic stroke not to initiate statins or not to increase the dose. Ischemic strokes, they prevent. So if the patient had ischemic stroke, I would have increased the dose of statins. But then I would also like to look at the lipid profile. Before telling you the exact dose of statin, it is very important to know what is the LDL level and the non-HDL level. I'm not going to treat him blindly without knowing the lipid levels. So these are my points that I would like to mention.
Yes, sir. So in this case, we have to check the lipid profile, and depends upon his lipid profile, we should have the moderate decrease in the cholesterol, and specifically we have to see the LDL level, and we use the judicious use of the statins in the form of atorvastatin 20 or 40 milligrams, depends upon the LDL level. Now my third question to Dr. Prashant, as you have been presented the case, what other investigations you would like to do in this patient? You have been done the CT scan, you have been done the HbA1c, you have been done the lipid, and what other investigations bedside or in your clinic or in your hospital you would like to do in this patient? 1, 2, 3 additional.
So the routine investigation, the blood investigations, the complete sugar profile, fasting, PP, HbA1c, his LFT, his coagulation profile needs to be done. His lipid profile needs to be done.
What else? Which is very important in this patient?
Carotid Doppler.
Okay, fine. Anything else? All CVA patient, we should go for the echo Doppler. We have to look after, as well as the bedside ECG, because he's a 60 years old.
Yes, sir.
Having a history of hypertension. So we should go for the ECG along with the echo. And if the facility is available, you can go for the echo Doppler and carotid Doppler.
Okay, sir.
So after the management of the mannitol as well as the statin and these things, anything else you would like to add in this patient?
Sir, physiotherapy rehabilitation part, apart from the main treatment, that is.
Yeah, very good.
So I think the chairperson should conclude the session. We have enough questions and it was very fruitful, I must agree. So Chairman, sir, Dr. Dhameja.
So I think the case was presented very well with the focus on clinical examination, and a good discussion followed that. So there were some very apt questions like role of statins in intracerebral hemorrhage. There is some evidence that statins do increase the prevalence of intracerebral hemorrhage. So there was in 80s and 90s, people were a little scared of using high dose statin, but now, of course, given the comorbid conditions and taking a holistic view, statins can be used in a low to moderate doses if the patient has a high risk profile. So something like this is very important to know that. The other thing is, of course, the discussion in depth about the etiology and management of hypertension in these patients. I think Dr. Prashant presented very well, and I must compliment all the panelists and the audience who took part in the discussion. And I think any final comments from the organizers?
In agenda, the last item is comment by our dean. I think Dr. Virmani has already discussed everything. Anything else you want to add, Dr. Virmani?
Yeah, just to say that I must congratulate Dr. Prashant Pandey for presenting the case. Wonderful. It took me back to my PG years. If you remember, Lohani, how we used to prepare and present. I was just remembering those years way back in 82, 83. And he took me right back. It was a very fond memory, the way he used to present. Nowadays, we just make a shortcut. And I was really impressed that you brought in a top neurologist like Dr. Dhameja and Dr. Thau and Dr. Jayant Sharma. It's wonderful to get people like them. And Dr. Sharma was just questioning like a true MD or examiner or DM examiner. It's really wonderful. Really wonderful. I've learned a lot today. Thank you.
Thank you very much, Dr. Virmani. And now the last item on the agenda, I request our dynamic secretary, Dr. Abhishek, to propose a vote of thanks.
Thank you, sir. First of all, I thank our founder president, Professor Rai, sir, National President, Dr. K.K. Parikh, sir, and Dean, Dr. Virmani, sir, for encouraging me to hold such meetings. A lot of thanks and praise to my teacher, Dr. R.K. Dhamija, sir, for sparing an hour for me. And I must admit that whenever I call sir on the clinical platform, he is always ready. I remember I have called Dr. Dhamija sir to just a simple CME in AIMS in 2015, and sir was there. And earlier also in 2019, I think sir has given a talk on the platform of CCDSI. So thank you, sir. Thanks a lot. Thanks for encouraging me or helping me at the moments I want your help. I thank my senior, my good friend, Dr. S.K. Gautam, sir, and Dr. Siddiqui, sir, for taking the responsibility of PG curriculum on their shoulders. And seeing the participation of today, that is, we have reached almost 70 at a time and not less than 60, 65 throughout the session. I am very thankful and very hopeful that these two duo will keep the PG curriculum of CCDSI on the high note. Thank you, sir. Thanks again. I thank Dr. Harmohan Sahu, a very loved junior and very well-behaved doctor, an upcoming neurologist, for helping to prepare the case. I think Harmohan must have monitored that case, and Prashant has presented very well. At the level of postgraduate 3, I think I was far inferior than Prashant. So congratulations to Prashant also, and thanks to you also. I also thank the senior doctors, Dr. P.K. Agrawal, Prince, Dr. Rohini, and many of our colleagues who has been there throughout the past 1 hour in this discussion. I thank all the postgraduate fellows, postgraduate candidates across the medical colleges. I can see the GSPM, Katihar Medical College, Heritage Institute, Lady Hardy Medical College, Patna Medical College, and also the faculty from Assam. So I am very thankful to all of you for participation, and I promise you that under the guidance of our top leadership and with the moderation and guidance of our scientific chairman, Dr. K.K. Lohani sir, our team, which is led by Dr. Siddiqui and Dr. S.K. Gautam, will bring most of the clinical cases in coming months in this discussion, and that will be a very beautiful ground for learning and reminding ourselves to the basics of the clinical science. I must thank the K.K. Lohani sir for giving me permission to think about all these things and always supporting me and helping me at the crucial moment. Thank you, Professor Lohani sir. At last, I thank all the participants, all the faculty members, and all the delegates. My senior executive, Dr. Mrityunjay Kumar Singh sir was also there throughout the session. Thank you, sir. Thank you, Mrityunjay sir. And thanks to all of you.
Abhishek, you must also thank Professor Siddiqui for mentoring such brilliant students.
Yes, sir.
Thank you, sir. It's always been all your blessings and all. Hopefully they do good, and this is what the target is, to bring up good doctors and good clinicians.
Good.
These students are heritage, sir.
Yeah.
Before we close the session, I've got just 2 lines to say. Number 1, congratulations to Dr. Pandey for wonderful presentation. And number 2, the team of Dr. Siddiqui and Dr. Gautam as professor in charge and co-in charge for case presentation curriculum of the CCDSI will continue till the next conference, and thereafter also hopefully the same team will continue.
Yes, sir.
So this
Sure.
is official announcement. Professor in charge and professor co-in charge, Dr. Siddiqui and Dr.
Sure, sir.
Gautam.
Absolutely. Sure, sir.
Thank you.
So
Thank
look
you.
after
Thank you,
into
Lohani sir, for
possibility.
leading us.
Dr. Lohani?
Lohani sir, thanks a lot to you for leading us and guiding us.
That is my responsibility as chairman scientific committee. And with a secretary like you, everything is possible. That's all I can say.
All blessings, sir.
Thank you, everybody. Thank you very much for joining
Thank you,
us.
sir.
Thank you.
Thank you, sir. Thank you.
Thank
Good
you,
night,
sir.
sir.
Thank you.
Good night.
Good night, sir.
Thank you,
See
everyone.
you,
Good
see
night.
you on the next.
Good night.
Thank you, sir.
Okay.
Good night, sir.
Thank you.
Thank you, sir.
Okay. वो भी बनाया उसका भी